Good afternoon. Welcome to Improving HIV Prevention, Screening, and Clinical Care for African Immigrants. This is the second webinar in our series focused on African immigrants, HIV, and hepatitis B. During the presentation, all participants will be in a listen-only mode. You may enter questions throughout the webinar by using the chat feature located in the lower left corner of your screen. Questions will be answered at the end of all three presentations. Please make questions clear and concise. As a reminder, this webinar is being recorded. This webinar is sponsored by the Multicultural AIDS Coalition, the oldest minority AIDS service organization in New England, dedicated to mobilizing communities of color to end the HIV/AIDS epidemic. The Multicultural AIDS Coalition's Cultural Competency Series is supported by the New England AIDS Education and Training Center, METEC, Minority AIDS Initiative, through a grant from the Health Resources and Services Administration, HRSA. Continuing education units are offered for nurses and social workers. To receive continuing education units for this program, participants must 1. Read the learning objectives and faculty disclosures, 2. Attend the program in its entirety, 3. Answer any polling questions presented, and 4. Complete an evaluation form. A certificate will be emailed to participants within 4 weeks. The speakers and planning committee members for this course have been asked to disclose any significant relationships with commercial entities that are either providing financial support for this program or whose products or services are mentioned during their presentations. There are no disclosures to report by speakers and planning committee members. The training objectives are provided. This webinar is designed to be interactive. Participants are encouraged to ask questions throughout the presentation by the chat box located in the lower left corner of your screen. Questions will be answered at the end of all three presentations. Please make questions clear and concise. There will also be polling questions so that faculty can build on your knowledge and experiences. Please participate by choosing an answer when the polling questions are displayed. Immediately at the end of the training, you will receive the evaluation. Keep your web browser window open, and in place of the webinar screen, a pop-up window will appear with questions. Please complete. The evaluation will provide vital information to help improve the webinar and also document who participated. Now I will invite Janice Hyatt, Regional Resource Coordinator from HHS, HIV/AIDS Regional Resource Network Program, to get us started.
Thank you, Rachel, and good afternoon. Before we have our first presenter, we would like to get a sense of who is participating on the webinar. Please select the appropriate category under which you provide services. Okay, great. So it looks like the majority of us are participating as non-clinical organizations, or those of you that work for community-based organizations. So thank you for that. Our second polling question is asking what is your primary role at your agency? Okay. So it looks like the majority are other, which would actually explain the last question. So it's helpful for us, first of all, thank you everyone for participating in that, and it's helpful for us to get a better understanding of who's participating on the call, and it gives our presenters an opportunity to sort of tailor their remarks based on the participants. Now I'll turn it back over to our moderator who will introduce the first speaker.
Now we will have our first presenter, Dr. Kwakwa. Dr. Kwakwa is a physician specializing in HIV medicine, currently serving as Director of HIV Clinical Services for the Philadelphia Health Department. She has worked in the field of HIV for the past 17 years. In Philadelphia, she has worked tirelessly as physician, educator, and advocate for those living with and affected by HIV. Her particular areas of interest and research include HIV in women, HIV in the Black community, and access to care for the HIV positive. Having grown up in Ghana, she also has an interest in issues relating to HIV in the developing world and HIV in the immigrant U.S. population.
Thank you. Good afternoon, everyone, and thank you so much for taking time out of your busy schedules at the beginning of the week to join us for this webinar today. This slide just gives the information on who I am, and as has been mentioned before, I have no disclosures. So we currently, as of the 2010 census, we had a little over 3 million African-born individuals living in the U.S., according to the census. Now, estimates are that those numbers may be higher than that. But our policies here in the U.S. definitely impact this large and growing population. And I should say that of the 3.1 million or so, the vast majority are from sub-Saharan Africa. There's fewer than 500,000, again, according to the census, from North Africa. So we are going to take a look at some of these policies, specifically looking at the Affordable Care Act, also the lifting of the HIV entry ban, and on opt-out HIV testing, and also look at some of the recommendations for hepatitis B testing issued by the Centers for Disease Control. Before we start, a few polling questions. What proportion of clients served by your program or practice are African immigrants? Please click on the answer that seems that best suits your practice. Okay, it looks like about half, fewer than 10%, but then there's a good number serving greater than 40%. So thank you for participating in that, and that's useful to know. What are the most urgent needs of your African immigrant clients? Resources, again, exactly half, and medical, a close second. Okay. And finally, what support would be most helpful for your helpful for your programs or practices to better support African immigrant clients? Excellent. This is very useful information, so thank you all for participating in those polling questions. And so let us begin the presentation looking at the Affordable Care Act and how it impacts Africans in the U.S. Now, since the Affordable Care Act has been signed, we've heard about a lot of different provisions of the law but it's very seldom that the impact on African or other immigrants is discussed. So let's take a look at some of the ways. Now, for naturalized citizens from Africa, the impact is exactly the same as it is for U.S.-born citizens. And so there is coverage for people who have pre-existing conditions, something that did not predate the law. There is expansion of Medicaid up to 138% of the federal poverty level. Now, this is happening in many but not all states. And for those above the Medicaid expansion level, there are premium tax credits for individuals with incomes between 138 and 400% of the federal poverty level. And then there are other benefits which have been widely touted, such as coverage for dependents up to age 26 and preventive care at no additional cost. Now, with all of this comes the individual mandate or the requirement to obtain health insurance coverage or to be subject to a fine. Now, for those who are not naturalized citizens, there is a whole set of provisions written for lawfully present residents, or LPRs. And this slide shows a short list of those who are regarded as lawfully present residents. It includes refugees, asylees, some trafficking and domestic violence survivors, and their derivatives or family members, people granted withholding of deportation or removal, and some conditional entrants. And there's a whole list of visas which come under this category of lawfully present residents. This includes the H-1 visa and some student visas and others. Now, the lawfully present residents are divided into two categories. Those who have been here greater than 5 years have benefits that are different from the others. And so for those who have been here for more than 5 years, again, the coverage under the Affordable Care Act, it's just like it is for U.S.-born citizens. For those who have been here less than 5 years, though, the provisions are a little bit different. But looking at immigrants and the Affordable Care Act in general, it is anticipated that there will be substantial reductions in the rates of uninsurance among naturalized citizens and lawfully present residents in the U.S. for more than 5 years. It is anticipated that the effect will be smaller for immigrant children because their pre-Affordable Care Act coverage was already better. Now, non-citizen children, and there's been a study, at least one study that has noted this, non-citizen children and children with non-citizen parents have been shown to participate in Medicaid and CHIP at lower rates. And for this reason, it is important to address barriers to enrollment and retention for immigrant populations, even though the Affordable Care Act expands coverage. It's still important to address these barriers because it's been shown that enrollment and participation rates in plans for which immigrants are eligible is lower. Now, for lawfully permanent residents who've been here for less than 5 years, the coverage is quite different. For those who are non-elderly and who have incomes falling between 138% and 400% of the federal poverty level, subsidized coverage through the health insurance exchange is available to them. But for those with income levels less than 138% of the federal poverty level who would ordinarily qualify for expanded Medicaid, they will not be eligible for Medicaid until they've established at least 5 years residence in the U.S. They may qualify for exchange subsidies if they pay 2% of their income, but for those whose income levels are very low, that may pose an undue hardship. The subsidies, even when they do qualify, are significantly less generous than coverage through Medicaid. And for undocumented immigrants, the situation is still worse. They are ineligible for Medicaid or CHIP. They are ineligible for subsidies on the exchange. They are not subject to the individual mandate. And importantly, they are also excluded from temporary high-risk pools. Now, what they are eligible for is emergency coverage under Medicaid if they meet criteria, and the criteria are usually income criteria, state residence, and medical eligibility. Now, while this is the law, I will say that since the law went into effect in the state of Pennsylvania, we've had slightly more difficulty getting emergency coverage under Medicaid for undocumented immigrants. We are ultimately able to get it, but I find, and this is purely my experience, that it takes just a little bit more to do that. Now, in spite of the difficulties for undocumented immigrants, the reality is that in many families where some people may qualify for coverage and some people may not, the family financial burden for health costs is still reduced. Access to care still, in large part, may depend on the ability and the willingness of safety net providers such as community health centers and health departments to serve this population. Now, there is a mechanism for those living with HIV or AIDS in this country for care access through the Ryan White program. And it's important to note that it's explicitly stated in the Affordable Care Act that all participating health plans are required to provide information in a culturally and linguistically appropriate manner. One issue when it comes to the Affordable Care Act is the impact on mixed immigrant families. And mixed immigrant families are not uncommon, where you may have parents who may be undocumented and an older child on a student visa and maybe a younger child born in the U.S. who's a U.S. citizen. The eligibility rules distinguish all of these categories, but the statuses are often mixed within the same household. Something we see quite often, for example, is a family that is here illegally with visiting family members who overstay their visa, for example, and then they have somebody who's out of status within the same household. They are less likely to enroll because of a variety of barriers, and those barriers are outlined, at least some of them, on this slide. There is a lot of confusion about eligibility for the Affordable Care Act and how to navigate it for those who know or think they may be eligible. There is a high degree of fear of immigration enforcement and a reluctance to divulge some private information in the process of applying for coverage. Some people may not have a social security number or may be unwilling to provide it or may be unwilling to provide information about their employment status or their income level. And we see this even at the level of the health department when we need this information to apply for coverage or to apply for the AIDS drug assistance program for patients. There is also a widespread fear of denial of a green card on public charge grounds, so that people may be unwilling to apply for the Affordable Care Act, thinking that that coverage may be held against them as they apply for a green card in the future. Language assistance sometimes poses a barrier, or fear or lack of language assistance, and also fear of discrimination in attitudes and behavior. The cost of participation also, particularly for those at the lower end of the income scale, or maybe for people who may be doing a little bit better financially but maybe supporting large families, extended families back home, the cost of participation, even a low cost, can pose a significant barrier. So, to the next policy, which is the HIV entry ban. And this was the law that essentially said that people immigrating to the U.S. or traveling to the U.S. for that matter, who had HIV were not admissible essentially. So essentially the history of this entry ban is that beginning in 1952, the Immigration and Nationality Act mandated that immigrants afflicted with any dangerous contagious disease were excluded from admission into the U.S. In 1987, Congress added HIV to this list of dangerous contagious diseases. And so HIV essentially constituted a reason to exclude people from admission into the U.S. Now, there were ways to overcome that barrier, but it was a quite effective barrier. And this had been in effect since August of 1987. Now, recently, 5 years ago in January of 2010, the Centers for Disease Control removed HIV from the definition of communicable diseases of public health significance and also removed it from the scope of examinations for immigrants effective January 4th. And so while this entry ban was in effect, everybody immigrating to the U.S. legally was mandated to undergo an HIV test as a part of an immigration medical exam. And if that test was positive, then that person was barred from getting a green card unless they were able to show that they would not become a public charge and that they were able to take care of themselves. And so as a result of this rule being lifted, immigrants are no longer inadmissible into the U.S. based solely on their HIV status, and they are no longer required to undergo HIV testing as a part of the medical exam for U.S. immigration. The lifting of this entry ban was in large part it was one of the main reasons why the International AIDS Conference was held in Washington, D.C. in 2012. It was the first time it had been held in this country for more than a couple of decades, precisely because this ban was in place at the time. And so the next slide kind of gives you a clearer timeline of when the administrative ban was instituted, the statutory ban, and when Congress voted to lift the ban, and when President Obama finally signed the law lifting the entry ban. Now, how has this policy, the lifting of the ban, impacted people with HIV from Africa living in the U.S.? This is something that we looked at here among our patients here in the health department. Between 2007 and 2008, for those 2 years, we had 234 foreign-born HIV-positive individuals in care in our city health centers. Now, more than half of these were from the continent of Africa. Now, looking at how they were diagnosed, 31% were diagnosed during an illness, 19% were diagnosed during immigration medical exams, and 13% in reproductive care settings. And so we decided to take another look at this since the lifting of the entry ban essentially eliminated one path to HIV testing, if you were. The people at Brown University, Dr. Winston and Dr. Beckwith, while the process of lifting the entry ban was going on, had written a fairly interesting opinion paper warning of the potential loss of one avenue to testing with the lifting of the ban. Now, let me be clear, nobody opposes the lifting of the entry ban that I'm talking about. We were only concerned about putting in place alternative mechanisms for testing for this immigrant population. And so here in Philadelphia, we've had a project, an ongoing project we call the African Diaspora Health Initiative, and this slide essentially outlines what the project is. It's a series of clinics without walls in collaboration with local African and Caribbean organizations to engage African and Caribbean immigrant communities in HIV testing. Now, as a part of the information we collect length of stay in the U.S., we collect country of origin data, and we also collect past testing history. And so what we decided to do was look at this data collected through this project to see past HIV testing history for those who came before the lifting of the ban and compare it to past HIV testing history for those who have been here only since the ban was lifted. And this slide shows some of the data. When 3,000 people had participated, 3,249, 552 of them, or 17%, had been in the U.S. since the ban was lifted. Overall, the African-born cohort had a higher previous testing history compared to the Caribbean cohort. But also, those who entered the U.S. after the ban was lifted reported lower previous HIV testing rates. And you see the percentages here, 52.9 compared with 61.9% for those who had been here before the ban was lifted. We looked at it by gender, and you see that regardless of gender, there was a drop in previous HIV testing rates. Now, this was not statistically significant, but there was a trend to lower testing rates for both men and women for those coming after the ban was lifted compared to those who were here before the ban was lifted. And so essentially what this says to us, and the message we think that this analysis gets across, is that the lifting of the HIV ban is a wonderful thing. It was a great success, advocacy success, and based on solid public health information. But we do need to consider that with the elimination of this avenue to testing, we need to create other opportunities for HIV testing for this immigrant population. Which brings me to opt-out HIV testing. And here, in opt-out HIV testing, consent for testing is assumed unless the patient specifically opts out. And it's a mechanism of testing that substantially increases participation in testing, and it's been promoted and recommended by the Centers for Disease Control, and it's now widely available at many healthcare facilities. But it's important to recognize that immigrant populations have access to opt-out testing only to the degree that they access care at these facilities at all. And we know that the barriers for immigrant populations, for African immigrants and others, for accessing care at our established healthcare facilities are numerous, are significant, and are slightly different from the barriers that we see with the native-born population. And so our blanket opt-out HIV testing, test and treat, may not be reaching this population to the degree that we would like to see. We don't have any data on opt-out rates among immigrant populations specifically. Hepatitis B screening policies also specifically mention African populations. And according to the ACP, the major risk factor to consider for hepatitis B is the country of origin, and the continent of Africa is widely known to have a relatively high prevalence of hepatitis B. And so Africa and Asia are the two main continents for where hepatitis B prevalence is high, and where immigrants to the U.S. are recommended to have routine hepatitis B testing, in addition to some other parts of South America and the Middle East. So all people born in the U.S. were not vaccinated at birth and have at least one parent born in a country with high hepatitis B rates also, the recommendation is to test them, as the recommendation is for people living with someone who has hepatitis B. Now, many of our African-born immigrant populations in the U.S. are at high risk for hepatitis B. In our health center, we find about a 10 to 15% chronic hepatitis B rate in this population, and very few are previously aware of their hepatitis B status. So it's an important screening test to conduct and to engage the community in. So in closing, I will say that it's a wonderful thing that many immigrants are newly eligible for health insurance, but we need to work to reduce barriers to enrollment, to educate the community, and to get the word out that that immigrant families and immigrant persons may be eligible for this coverage. With the lifting of the HIV entry ban, alternative strategies to engage immigrant populations in HIV testing are necessary. These strategies need to be culturally competent. They need to be developed with these populations in mind and with these populations at the table. Routine opt-out HIV testing is an effective method of improving participation in screening, but it must be paired with, again, culturally competent outreach to immigrant community as well as community-based engagement. The CDC recommends hepatitis B testing for African immigrants and others. It must be routinized, and again, it must be paired with outreach and education. Thank you so much for your time, and I will pass it on to Janice.
Thank you, Dr. Kwakwa. Our next presenter is Ms. Nnaji. As a community health activist, Ms. Nnaji focuses on health equity, specifically geared towards mobilizing communities of color in Massachusetts to end the HIV/AIDS epidemic and broader conditions that fuel the epidemic. Currently, Ms. Nnaji is the program director at the Multicultural AIDS Coalition in Boston, where she develops and currently directs the Africans for Improved Access program, an HIV prevention and screening program targeting African immigrants and refugees in Massachusetts. She is passionate about her work and is committed to bringing the voice and needs of African immigrant communities to the table of health policy, research, and service delivery in a way that recognizes community assets and respects cultural values.
Thank you very much. Today I will talk about community-based programming for engaging African immigrants and HIV prevention screening and linkage to care services. I will start by discussing a continuum for examining the effectiveness of interventions. This will lay a framework for the community-based programming that I will talk about later on in the presentation. Then I will give a brief history of the program, the Africans for Improved Access program, before presenting some of the work that we do here in Massachusetts with African immigrants. So there are several paradigms for developing best practices or interventions. As shown on the slide, there are interventions developed from evidence-based practice, practice-based evidence, and community-defined evidence. Each have their pros and cons. This continuum is actually better defined in mental health, but I think it's very applicable to HIV prevention practice. So let's start with evidence-based practice. Evidence-based practice is seen as the golden standard. In the HIV prevention field, we would equate this to the CDC-funded EPIs and DEBIs. And I know that many of you are familiar with these behavior interventions and best practices that were scientifically proven to significantly reduce HIV risk or promote HIV care. So evidence-based practices have to be proven efficacy using scientific research methods. Also, you'll see that evidence-based practices tend to be developed in a research paradigm and then needing to be implemented within programs that have to deal with the day-to-day realities of clients, and programs often end up having to structure their operations in order to adhere to the core elements of these evidence-based practices. And then evidence-based practice interventions also are known to be adapted to other populations. So for example, in HIV, when you have an evidence-based intervention that has been proven effective with injection drug users, what does it mean in order to be able to adapt that program or that intervention for men who have sex with men? So moving to practice-based evidence. This addresses relevant and important outcomes derived from and supportive of the social and cultural understandings of a particular community. This is not necessarily generated by controlled research, but is seen as being equally valid amongst the community or the recipients of the services. Practice-based evidence can be informed or supported by behavior change models. They can also be an adapted intervention from evidence-based practice interventions. Hence, they have the potential of being scientifically tested with hopefully culturally appropriate methods and moving into being an evidence-based intervention. Lastly, we have community-defined evidence, or CDE. It's a set of practices that have been found to yield positive results as determined through ongoing efforts to achieve community cohesiveness. And so as you see, these practices actually emerge from the community, and so they are part of the social fabric already of the community. They can be measured in formal and informal ways. So formal ways might be some of our standard quantitative measures that we use. Informal might be things around the informal things that are not tangible. So you can think about trust, you can think about relationship, partnership development, things of those things. And then also they are endorsed, their success is endorsed from the community. And lastly, they tend to be more flexible because they adhere to the changing dynamics of a community. So let's go to our first polling question. Our first polling question is, what level of evidence do you typically implement in your work? Is it evidence-based practice only? Is it practice-based evidence only? Is it community-defined evidence only? Or is it a combination of two? Or is it all three? Please select and hit submit. So I see the majority of individuals are all three. So they implement all three levels of evidence. And this is typical. The levels of evidence are complementary, so they should be integrated in different ways in your program according to the population that you're serving, according to the measures or the outcomes that you are looking at. It doesn't have to be an either-or situation. For today, I'm going to focus on practice-based evidence and community-defined evidence strategies that we have used in the Africans for Improved Access program. In our experience, when using approaches to adapt an intervention such as the CDC, DEBIs, or EBIs, at times the core components, which cannot be changed, create additional barriers towards implementation. We all know that once the core components are changed, the intervention is no longer proven effective based on scientific research. So for us, in order to effectively address the HIV epidemic in the African immigrant community, we need to take into consideration social and cultural factors, including the overwhelming impact of stigma. As an emerging community in the U.S., the HIV challenges of this community have not been addressed by traditional evidence-based interventions, and hence we have looked at strategies that are more grounded in the social and cultural understandings of the community. So to give a little historical background of the program, I think this is important because, one, it acknowledges the process it took to identify the problem, and then it also acknowledges the process in which strategies were developed to address the problem. So as you see, starting in 1994, the Massachusetts Department of Public Health convened a group of African professionals. The goal was to find ways to address reproductive health, but also the increasing rates of HIV being seen in Boston's local HIV clinics amongst African immigrant women in particular. The task force decided to move forward and implement an HIV needs assessment to look at attitudes, beliefs, and barriers towards HIV services. At the same time, the Multicultural AIDS Coalition was being funded through CDC to develop a Black HIV/AIDS coalition. Leadership here at the Multicultural AIDS Coalition recognized early in the beginning of this process that Black is not a homogeneous community, and so there is a need to create sub-coalitions that recognize the unique differences within our community. Hence, a task force or a sub-coalition was created focused on African immigrants. The sub-coalition really wanted to identify a culturally appropriate way to bring awareness about HIV and to look at the community readiness to even talk about HIV. So the task force created In Our House an African Story. This is actually a video that was developed by the community, mostly Africans living with HIV. And it depicts an African family that is trying to cope with challenges delicate issues around culture, relationships, and HIV. This video was funded by multiple state and federal funding sources. So in 2001, the video was actually launched at the first conference that was here in Massachusetts, and then 2 years later, Africans for Improved Access program was funded by the Office of HIV/AIDS. So the program is based on 4 principles, and these principles really govern the way the program operates and the way in which we build relationships with the community. So for the remaining of the presentation, I'm going to briefly review the principles, and I'll provide you with ways our program has operationalized them in interventions and in activities. So the first principle is nurture a community-led process in all activities. As shown on the slide, this includes community organizations and individuals having a central and very active responsibility in the program, so taking an active role in the program. This also includes community health workers that reflect the diversity of the population by gender, by language, by country of origin. And it also includes AFIA serving as a convener in the community. And we see our role as being a convener to bring members and organizations together around a specific issue. This supports cohesiveness and civic engagement within the community, which ultimately supports the work that we do around HIV and AIDS. So let me provide an example on how we actually achieve Principle 1. So the first example is our safety net parties. The goal of safety net parties is to increase awareness about HIV, to increase condom use, the utilization of condoms, and also to increase individuals, particularly African women, knowing their HIV status. It was originally developed for African American women and Latino women, and then was later adapted by the AFIA program for African immigrant women. Safety net parties are a 5-hour group level intervention. It has 3 components. It includes a basic risk assessment, it includes on-site HIV testing, and it also includes a group discussion around HIV-related topics such as body awareness, female reproductive system, HIV, biomedical HIV prevention research, and condom use. The groups are safety net parties are culturally and linguistically appropriate because they reflect the traditional way in which women have social gatherings. And it begins with food, and it has games and good conversation about sex and sexuality. This is one of our interventions that we define as community-led because the groups are hosted by community women. AFIA staff actually engage community women to recruit 6 to 10 other women who are a part of their social network. This could include women who are their sister, their niece, even their mother, church members, and their friends. The group happens in the home of the community woman who is hosting the event. Recently, we conducted an evaluation of our safety net parties held between July 2011 and May 2013. There were 14 safety net party groups that reached 144 African-born or first-generation African women. As you see on the slide, the majority of the women were single. They had sexual partners in the past 12 months, 1, 2, or 3 sexual partners within the past 12 months, and they never used condoms during sexual interactions. Because of the safety net party, we found that the majority increased their knowledge by two levels, particularly around 3 areas: female reproductive system, HIV and AIDS, and prevention of HIV and other STDs. Knowledge for this evaluation was measured using a 5-point scale from poor to high. In addition, participants who participated in the safety net party, 63% of them took an HIV test that was provided on-site in the home of a community woman. And the majority were determined or hoped to change their behaviors related to testing and condom use. So we deem this intervention as a success because it meets the programmatic objectives. It also is successful because women readily opened their homes and committed time to host the group. Hence, we see this group as being endorsed by the community and successful as defined by the community. Another example is the African Faith Collaborative. Now, this is an example of how the program serves as a convener. So the African Faith Collaborative was formed in 2006, as you see. It has more than 20 faith organizations, mostly churches. And this collaborative comes together on a yearly basis to actually implement HIV services. So this could include distributing materials, and we do have some churches that distribute condoms. And it also includes commemorating Week of Prayer and other HIV awareness days, and providing on-site HIV testing at the events. Now the collaborative really operates organically, whereas pastors give guest sermons on HIV at various churches, and the collaborative seeks information from AFIA on other diseases, such as prostate cancer, diabetes, and other health issues that are happening currently in the African community here in Massachusetts. So principle 2, build long-lasting bridges in the community. These relationships with community organizations and individuals, such as faith organizations, civic resettlement agencies, and African businesses, are a way for us to increase awareness about HIV prevention and screening. They also serve another purpose in that they serve as a resource to ensure that Africans living with HIV or Africans in general are accessing culturally and linguistically appropriate services. And so what we found is that there is a tremendous need in building long-lasting relationships with the community to do it within humility, trust, and patience, a lot of patience. And it requires us to be constantly visible in the community. So that means that we have to be integrated into the social fabric of the community. If one of the pastors is getting married, we go to the event. If there is something else happening in the community not related to HIV, we go to the event, so that community members and community leaders can see that we are committed to the overall health of the community. So let me provide a case study to show this, particularly to show how building bridges with community organizations support having culturally and linguistically appropriate services within our healthcare system. So this case study, Ms. Dembele is a 39-year-old female from Ivory Coast. After her husband's death, she came here to the United States on a visiting visa, leaving behind 3 daughters. Now, she speaks a very local dialect. She is not literate in her native language nor in the official language in Ivory Coast, which is French. And she is not being provided language services through interpreter services at the community health center because her native language is not provided. Since she arrived in the U.S., she has learned limited broken English or pidgin English. So Ms. Dembele goes to the ER complaining of common symptoms related to HIV. She gets tested and she's diagnosed with HIV. For 1 year, her case manager has had difficulty getting her to adhere to treatment, and also she constantly travels in and out of state and never makes her appointments. So the case manager contacted us asking for help. How is Principle 2 relevant? So please select your answer. Better understand patient situation, convene a meeting with the community, provide support to address language, or it's not applicable due to the stigma in the community, or 1 in 3. Oh, great. So the majority of individuals picked 1 in 3, to better understand the patient's situation and to provide support to address the language barrier, which is correct. So to close this case study, the staff contacted the president of the Ivorian Community Association, who then identified a community member who speaks Ms. Dembele's native language. The community member was introduced to the client over the phone, over several conversations over the phone. It was later identified that she didn't even know she had HIV. She actually thought that she had malaria and only needed to take the medication 1 time, and was even confused at why the case manager was constantly calling her. She was traveling with her family member because she didn't have stable housing, and her family member was someone who sold arts and crafts. And so she had to travel with her family member because she didn't have any other place to stay. So the way that it ended was that the community member became trained as an interpreter. So over time, the community health center actually hired this person, trained this person, and this person is an official interpreter. And then Ms. Dembele also received housing assistance, ESL classes, legal assistance, and other supportive services to help her understand her HIV status. Now let's look at Principle 3. Incorporate African-centered social and cultural values and practices. So we based our messaging to the community, we based it on a collective understanding. So there's a communal nature within most African societies that encourage making decisions as it relates to the common good of the family and the community. The family and the community are the center, and they must accept the reality that everybody is collectively responsible for failures as well as for victories and achievements. Hence, we situate HIV within the context of we versus you or I. This also allows HIV stigma to be reduced because it facilitates individuals who are living with the virus not to have to isolate themselves or be identified with the disease, giving us the ability to have more open discussions. And also what we recognize is that we need to incorporate in our programming cultural ways of learning and teaching. Language and communication isn't only about translating terms. It's also important to present concepts or messages in the cultural ways communities communicate, learn, and teach. One of the ways, or two of the ways that we do this is one through African Proverbs, which are culturally rooted expressions of wisdom acquired through reflections, experiences, observations, and general knowledge. So there's a common understanding or norm around African Proverbs. Also, we use the arts in a way that we incorporate HIV messages to talk about sensitive topics in a more fair playing ground. It's similar to educatement. So let's see how well we can interpret African proverbs. So how would you interpret this proverb? A problem shared is a problem solved. Okay, so the majority of people said that in relating it to a HIV message, they would relate it to get talking. Let's look at another proverb. How would you interpret no one knows caution as regret? Okay, so the majority of individuals said get tested. So this is the way that we have used Proverbs in our HIV messaging. And I have to say, with a lot of African Proverbs, there's no wrong way of interpreting. However, I would suggest that you consult with members in the African community to ensure that you're not using a proverb that is anti-productive to what you're trying to do in terms of HIV prevention and education. So these are the ways in which we've used some proverbs, and definitely some of them can apply to different HIV messages. So another way in which we have incorporated social and cultural understandings into our programming is through the African Health Cup. Soccer, as many of you probably know, is a popular cultural activity amongst African immigrant men and within the African immigrant community in general. So in 2000, the Africans for Improved Access program collaborated with various community members to begin hosting the African Health Cup. So we define the African Health Cup as a community-level intervention, and in 2010 it started with 6 teams. Now, in 2015, we're up to 12 teams. All team members and coaches are required to attend a discussion group. Discussion group is focused on HIV-related topics, so it includes HIV stigma. We have an African person living with the virus come and speak. It also includes a doctor coming to talk about HIV medication and various other topics. Over the years, we've had over 500 spectators, and we always have on-site screenings, including HIV testing. And everybody's welcome to come to our African Health Cup this year, which is July 11th in Massachusetts. So lastly, our last principle is maintain strong linkages with other needed services and overarching issues. As shown in several of the mentioned interventions, AFIA includes HIV testing in all activities, because one of our key messages is that knowing your HIV status, as you know, is the first step to HIV prevention. So when we're doing, of course, individual interventions, group-level interventions, and community interventions, all of AFIA events and interventions include HIV counseling and testing embedded. We also offer other health screenings. This could include BMI, blood pressure, diabetes screening. Linking to other services reduces the level of stigma associated with HIV testing, particularly within a public event. So we see offering health screenings, navigating individuals to health insurance enrollment, which the previous presenter talked about, the barriers around immigrants accessing health insurance, and we are seeing it more and more. Every year our numbers go up in terms of the number of individuals that need to be navigated for health insurance. And this doesn't just include immigrants, undocumented immigrants, it includes immigrants, African immigrants with different statuses. And so offering additional health screenings, navigating individuals to health insurance, and being active in other issues such as immigration reform or some of the local policies happening in Massachusetts, for us is very critical to our overall mission of the program to support a healthier African community. So I want to conclude with a couple of points. First, community-based organizations and grassroots organizations are well positioned to develop best practices for engaging African immigrants and also other emerging hard-to-reach communities. We're well positioned because, one, we have access to the community, we have established trust and relationships with the community, and in most cases, grassroots organizations reflect the community, thus they have insider understanding of cultural and structural factors that might prevent or might support the community in accessing HIV services. So the terms practice-based and community-defined evidence, again, are used to describe interventions that have evidence of effectiveness from the community, and they are supported and endorsed by the community. Most are not research-based, but have gone under some level of evaluation, and they are also seen as effective because of the overall experience of the organization over time. The next point I want to conclude with is there are various ways to engage the community. And hopefully, as you've seen through the presentation, ways to engage the community could include hiring community health workers, individuals who reflect the community as part of your workforce, as a critical integrated part of your workforce, recruiting community members to lead activities as I presented on in terms of the safety net intervention. Also working with community organizations to build awareness, such as the African Faith Collaborative, or serve as cultural brokers, such as the case study that I presented. Lastly, I want to highlight that HIV testing in community-based settings is essential to reaching this population. It helps in addressing critical barriers to testing, such as language, cultural stigma, and other factors. And I would strongly encourage us to continue to think about effective ways to support community-based organizations in doing HIV testing to reach the African immigrant population and to reach those who don't have other means of getting into services. Here are additional references, and thank you for having me.
Thank you, Ms. Nnaji. Our last presenter is Dr. Ojikutu, an assistant professor of medicine at Harvard Medical School and an associate physician within the Division of Global Health Equity at Brigham and Women's Hospital. She also holds a joint appointment within the Infectious Disease Division at Massachusetts General Hospital. Dr. Ojikutu has dedicated her career to rectifying disparities experienced by people living with or at risk for HIV, domestically and internationally. Her recent research explores the impact of structural factors and social determinants of health, such as crime, poverty, discrimination, immigration policy, on HIV transmission, clinical outcomes, and barriers to accessing care. She is particularly interested in the care and treatment of women and immigrants living with HIV in the U.S. Dr. Ojikutu maintains an active clinical practice focusing on the treatment of HIV, primary care, and general infectious diseases.
Okay, thanks. Good afternoon, and thanks to the organizers for inviting me to speak with you today. As was mentioned, I'm an infectious disease specialist and HIV doctor at Mass General Hospital, and I would estimate that probably half of my patients are immigrants from either Africa or from the Caribbean. And as was mentioned, I'm going to discuss care and treatment challenges amongst African immigrants living with HIV. I would also add that many of these challenges also apply to other immigrant populations. I realize that many of you are not clinicians, so I'm going to focus a lot of the cases on things that impact clinical care, but there are also issues that folks who are non-clinical can benefit from understanding more about and can use to engage and work with their clients on a non-clinical level. I also want to mention that though the cases are based on actual experiences that I have had treating African immigrant patients, the cases that I've tried to include are actually composites of several patients, and the names have been changed to respect patient confidentiality. Okay. So I have 4 learning objectives for this lecture. First, I'd like you to gain a better understanding of the implications of late testing and late presentation for HIV care and treatment, and to get a better sense of why this is a particularly relevant issue amongst African immigrants. Secondly, I'd like to raise awareness of the impact of stigma on clinical care. And thirdly, I'd like to, hopefully make you more aware of and be able to identify common mental health challenges faced by African immigrants. And lastly, I think it's important to acknowledge the need for linguistic competency in the care and treatment of all immigrant populations, as well as all of the patients or clients who you serve. So let's begin by briefly reviewing some data. Unfortunately, the data that we have describing the origins of non-U.S. born individuals living with HIV is limited. The CDC published surveillance data on non-U.S. born individuals living with HIV back in 2012 in JAMA. And this data estimated the number of immigrants diagnosed with HIV from various regions of the world between 2007 and 2010. And according to that data, approximately 14.5% of all immigrants diagnosed with HIV during this time period were from Africa. As you see here, this data only includes 46 states, if you read the title. And what that means is that we're not including some rather relevant states, including Massachusetts, where a considerable portion of Black individuals diagnosed with HIV infection between the time periods studied are non-U.S. born. And if you look at the number of patients that were included in the analysis, 25,255, that's actually significantly less than those who were actually diagnosed. But this is the number of people who the CDC had full information on. So clearly there's not complete information, and it isn't something that is required to collect at this point in time. So I'm sure that other lecturers who presented in this webinar series have mentioned this, but we do need additional data if we want to be able to make accurate assumptions about what's going on within non-U.S. born communities in regards to HIV infection. So to begin discussing our learning objectives, I'd like to turn to our first case. So Mr. Chona is a 52-year-old man who traveled from Cameroon to the U.S. 2 years ago on a visitor's visa, which has since expired. He is in the ER with a severe headache and stiff neck. He hasn't felt well for several months, has lost weight, and had night sweats. He has not seen a doctor. In the emergency room, he has a low-grade fever. A lumbar puncture was performed, and he was also tested for HIV, which was positive. His CD4 count, or his T-cell count, was noted to be 10, which is extremely low. It was determined eventually that he had TB meningitis. He was started on 4-drug therapy for tuberculosis and started on antiretroviral therapy in a delayed fashion, which was completely appropriate. And then after an extended hospital stay, he was discharged to follow up as an outpatient. So eventually Mr. Chona actually did well, but the way that he presented was rather unfortunate. TB meningitis is actually a rare opportunistic infection in the U.S., and in other parts of the world where TB is endemic, tuberculous meningitis is much more common in HIV-infected patients with very low CD4 counts, very low T-cell counts, who are severely immunodeficient, who have not yet started antiretroviral therapy. So if you were looking at this case and you were seeing Mr. Chioma as a case manager or a social worker, you might ask yourself, what is the most likely reason for his late presentation? Why is it that he presented so late? So let's look at our first question and see if we can answer this. Okay, so it looks like most respondents said that A and B are most likely, so both barriers to HIV testing and treatment in his home country of Cameroon and barriers to HIV care and treatment here in the U.S. Well, I think that that's a reasonable answer. The way that we have to look at it right now, because we don't completely have evidence for what's going on with a lot of patients who end up coming to the U.S. and being diagnosed initially for HIV late, is that we actually don't know what's going on with many of them. That's largely because we don't collect enough information to totally understand when people were sort of first diagnosed. Some people were first diagnosed in their home country, and then we don't sort of find out the reasons why they, ended up, not accessing care there, because HIV medication treatment is available in most settings. It's just maybe more difficult to get. There may be wait lists that are still active in some locations, but we don't know. And the issue that I wanted to really bring up here is that we really need to be collecting more information. I think we make a lot of assumptions about what's going on, but we really need more documentation to understand how and where to intervene as far as improving the care and access to treatment for immigrants of all origins coming to the U.S. who are living with HIV. So what we do know from the data that we have, both from the U.S. and Europe, is that African immigrants are more likely to present with low CD4 counts and severe immunosuppression than other individuals living with HIV. Actually, lateness to HIV testing and entering into care may be due, as I said, to barriers here in the U.S. as well as barriers in their home country, as well as just delays in migration. Studies in both the U.S. and in Europe have noted that African immigrants present with more advanced HIV infection than indigenous patients. But the good news is that amongst non-U.S. born individuals living with HIV, even though they tend to present with AIDS or with severely immunosuppressed more commonly than other individuals, they are actually more likely to survive at 1 year following an AIDS diagnosis, and no differences have been noted in the rate of HIV disease progression or mortality once they're engaged in care. And as I mentioned, Mr. Chioma his case is very true of a number of patients who I've seen, and all of them have been engaged and stayed engaged in care once they've actually gotten on treatment and connected with a provider. So there is some good news in this. We just need to hopefully decrease the time to getting tested and improve engagement and linkage to care. So to explore the causes of barriers to HIV testing amongst African immigrants, we conducted a study and found that there are significant differences in perceived risk for HIV infection, as we see here. 55% of African respondents believe that they were not at risk for HIV infection versus 41% of U.S.-born respondents in this survey. There were significant differences in desire to know one's HIV status. 21% of African immigrants didn't want to know their status versus 12% of U.S.-born individuals. And there were a small number of individuals who did not want to test because they were afraid that they would be deported. And then interestingly, there was no difference in the proportion of individuals who did not want the U.S. government to know if they were positive, irrespective of country of origin, whether they were native-born or they were African. So, there are other reasons why people have barriers to HIV testing and access to care, and stigma and discrimination are very potent inhibitors for people not to engage in care. So which one of the following statements is true? So I'm going to actually expound on these a little bit. So the first statement is basically saying, according to what you understand, HIV stigma is higher in the African immigrant community. The second response is internal stigma amongst people living with HIV has been associated with depression, or internal stigma amongst people living with HIV has been associated with non-adherence, as well as poor retention in care. And then the last statement is all are true. Okay, so I think pretty much everyone has voted, and the vast majority of respondents said that all are true, and that's absolutely correct. It's sort of an easy question. All of these statements are true. The reason why I posed this question was because the first answer was actually data are available suggesting that HIV stigma is higher amongst African immigrant communities than in U.S.-born communities, particularly U.S.-born Black communities. I think that, most of us who work with African immigrants or with immigrants in general, we have a sense of what are the common themes, what are the common thoughts, what are the cultural norms, cultural beliefs that people have as they pertain to HIV infection, but has data actually been collected to suggest that? And that is the case. There is data that's out there. One of the studies is actually done by myself as well as Chioma, and we work with the Multicultural AIDS Coalition on this study. And in this study, we were able to survey more than 1,000 respondents, and we compared levels of HIV stigma and HIV knowledge amongst U.S.-born, African-born, and Caribbean-born individuals. And we found that among survey respondents, U.S.-born respondents reported the lowest level of elevated stigma regarding HIV. And there were significantly more individuals who had high HIV stigma levels who were African or Caribbean. And as I mentioned in the study, we also looked at HIV knowledge, such as simple questions: awareness of HIV transmission risk, awareness of availability of antiretroviral therapy, the risks related to mother and child transmission, and we found that more African and Caribbean-born individuals had low rates of HIV knowledge than U.S.-born folks. So these are sort of concerning findings. But I think that this was actually a cross-sectional study. It wasn't representative of the entire African and Caribbean immigrant populations. So I think more work needs to be done to sort of figure out what the needs are and how much education is needed and what types of evidence-based interventions are needed to decrease HIV stigma in these communities. So I think that that's very important, but how does it relate to clinical care? Because as you recall, that's kind of the focus of this particular lecture. Well, what we know from a number of studies is that HIV stigma, it's initiated and perpetuated within communities. It's not initiated or maybe perpetuated within individuals, but it's really something that goes from the community level to the individual level. And we know that leads to this internal stigma within people living with HIV, and that internal stigma often leads to depression. I have a number of patients who are struggling with this issue and are afraid to disclose because of internal stigma. And then numerous studies have demonstrated that depression leads to poor retention in care and non-adherence to antiretroviral therapy. So it is very serious, and it's something where, as I said already, we need evidence-based interventions, particularly as it relates to African immigrant communities. Okay, so let's turn to another case. So this is Ms. Okafor. She's a 32-year-old woman who was diagnosed with HIV 8 years ago. 3 years ago, she fled northern Nigeria and became a refugee in Cameroon. She came to the U.S. as an asylee soon afterwards. You're seeing her as a new patient, so let's pretend you're a clinical provider. In the last week, she has taken her HIV medication sporadically, missing 4 out of 7 doses. She says that she has a 10 out of 10 headache all week long. Advil and Motrin help, but they don't completely eradicate the headache. Today, her headache pain is about 5 out of 10. She's afebrile, so she doesn't have a temperature, and the rest of her vital signs, her blood pressure, heart rate, respiratory rate, they're all stable. Her records show that she's presented with these same symptoms in the emergency room at least 4 times. She's had 2 MRIs in the last 2 years and 2 lumbar punctures. All were negative. She also underwent an extensive neurology consult, and they found no etiology for her headaches. Okay, so let's put on our clinical hats and just play like we're treating Ms. Okafor. What would you do next? This may be a tough question, but just in your mind, if you were in the emergency room, what would you want to do next? Okay, so let's move on to results. I know that one's a little bit tough just because it's sort of clinically oriented, but most of you guys got the right answer. So we want to refer her to a mental health professional. And that's really the best answer because it's most likely, given the fact that she's had an extensive workup, it's very recent, she's basically presenting with the same symptoms, that she probably has post-traumatic stress disorder and possibly some generalized anxiety, possibly with some depression included. And these symptoms are manifesting as her physical complaint of headache. And they can also manifest as lots of other physical symptoms, pain, fatigue, just other things that might mask and make you sort of not pay attention to the fact that she probably has a mental health issue. So those of you who work with asylees and refugees know that the prevalence of post-traumatic stress disorder, generalized anxiety, and other mental health disorders is high in that population. And I think sometimes people forget that many African refugees and asylees, as well as other African immigrants, they've fled from violence and conflict. At any one time, more than 30% of sub-Saharan Africans live in a state of recurrent or episodic emergency. And as you see all the red dots and dark purple dots on this map. And emergencies can include periods of unrest, displacement caused by political upheaval, violent unrest, short or long-term conflict, or even predictable or unpredictable environmental events. So just keeping that in mind when we're treating patients is important. Interestingly, mental health issues are a significant concern amongst African immigrants, and this isn't just for folks who are living with HIV, this is just in general, but referrals actually are rare. Now, why that may be, I don't really know. I mean, I could think of some general reasons. As I mentioned, maybe we don't think about this with African immigrants. Maybe we're afraid that it doesn't fit into their cultural paradigm, and that may be the case, but I think that you have to sort of work through your discussions with patients and see what they've tried, what they want to do, what they don't want to do, what they might feel comfortable doing. Do they prefer a support group, or would they want one-on-one counseling? Would they even want to take medication, say they have an anxiety disorder or depression? So I think that involves some discussion that either you have with the patient or you, as I said, refer them to a mental health professional. Interestingly, women are four times more likely to develop PTSD than men after adjusting for exposure to traumatic events. And PTSD, anxiety, and depression can all present with somatic or physical symptoms, so it's important to, as I said, not forget that in your differential. As you're thinking about all the things that could be wrong with somebody, certainly you think about the physical issues that could happen, because that's paramount, and you want to think about those issues too, but you want to remember that other things could be happening. And then just going back to, we talked about issues of depression and linkage to care and retention and adherence. We know that untreated mental health disorders have been associated with viral failure, virologic failure, and non-adherence. Okay, so let's move quickly on to another case. So Mr. Kande is a 36-year-old man living with HIV who's originally from Guinea. And I apologize, Guinea should be G-U-I-N-E-A. He has lived in the U.S. for the last 6 years. In his records, it says that he speaks his native language, which is Mandinka. He also speaks Spanish, Portuguese, and some English. He was diagnosed with HIV 6 years ago and started HIV medications at that time. You are his clinical provider again. You switched his medications from one pill once daily about 9 months ago because he said that he was having fatigue, and you thought that maybe it was due to the regimen, so you made that switch. So his new regimen is 3 tablets once per day. At his visit, you found an in-person Spanish translator who helped explain the regimen to him, and he was given some written materials in Spanish. His only other medication is an over-the-counter painkiller. At 6 months, his viral load was undetectable. So at 6 months, he was doing great on that regimen. So today, you see him in clinic, and then you have a Portuguese telephone translator. He tells you that he's doing well. He, again, reports 100% adherence to his medication. However, he says he's running low on one of his HIV medications, and he thinks it's the little blue one. Okay, so you say, okay, the little blue one, I know what that is. It's Truvada, it's the little blue pill. You provide him with a refill. So labs are drawn at this visit, and his viral load is now 2,200 copies per mil. So now he's not undetectable. So you say, oh, well, I guess maybe he thought he was 100% adherence, but he missed some doses. Not really sure what's going on here. So you call him and you ask him to come back in to talk about his adherence and tell him to bring his pillbox at that time. So via a Portuguese telephone translator, again, he says that he's still doing well, and he again reports 100% adherence. He doesn't understand why his viral load is now detectable. So you open his pillbox. Okay, so in his pillbox, if you look to the left of the screen, you see a picture of 3 pills that should have been included in his pillbox. Okay, it's not important what they are, but like I said, the blue one is Truvada. But when you look in his pillbox, you see the pills on the right. And do you notice a difference? I hope you guys notice a difference. So where it should be Truvada, where it says Gilead, it's actually an Aleve. Okay, now I'm going to be very frank with you and tell you that this really did happen with a patient of mine. Though this is a composite with a lot of other pieces in it, this actually is something that occurred. So clearly the blue tablet, which should have been Truvada, has been switched with Aleve. All right, so what would you have done differently in this case? If you were advising, if you were talking to the doctor, the nurse practitioner, physician assistant who was working with this patient, what would you have done differently? Would you have used in-person translation services throughout the entire, or for all the visits? I know he had it sometimes, but he didn't have it the whole time. Would you have assessed which one of the languages he felt most comfortable in and is actually fluent in? Would you have determined his literacy level? Now, linguistic competency is different from literacy level. Would you have done all of the above, or would you have done B and C? Now, B and C, or let's see, that would be 2. The second one and the third one would be to assess which one of the languages he feels most comfortable, is actually fluent in, and then the next one is determine his actual literacy level. Okay, so it looks like everybody has weighed in. So it looks like most people want to do all of the above. And I don't think that that's a bad answer, actually. The actual answer, or the answer that I selected, was B and C. Now, the reason why I selected B and C is because if you look at this issue of in-person translation versus phone translation or video translation, which has become very popular, you may have it at your site. It's at most of the hospitals in Boston. You have a video conference or, a telephone line. I usually use a telephone line, or if I feel like things just aren't going well, then I'll try to get an in-person translator. So if you look at the studies, phone interpretation has been found to be a reasonable proxy for in-person or video interpretation, and it's actually equally acceptable amongst patients in most studies. Okay. Now, with that being said, as I mentioned, sometimes if I can find somebody in person from the translation services, even though, it's obviously a big hospital, MGH and the Brigham are, busy and everything, and sometimes it's very hard to find in-person people, and especially if I have somebody who has some language issues beyond just having speaking a different language, but they, aren't speaking very clearly, or they've had a stroke or something of that nature, then certainly I do try to get an in-person translator. So I think B is not a bad thing. However, I think the key point I wanted to make is that I don't think in this case, and with the patients or the couple of patients who this composite case is made from, I don't think anyone really knew which of the languages the patient felt most comfortable in and actually felt fluent in and wanted to talk about health concerns in. Because those languages may be completely different. So understanding that is important in your ability to convey messages to any patient. And then not only do you need to know what language that the patient actually is fluent in, but then you also need to know their literacy level. Are they reading in these languages? It's quite possible that this particular patient isn't able to read in any of the languages. You really don't know. And I think Chioma mentioned in the last case study that she presented that the patient that she was referring to wasn't literate in even their native language. And, that may be the case for many patients that we see. And I don't think that many providers, whether they be clinical providers or, non-clinical providers of support systems, wraparound care, so on and so forth, we oftentimes don't take the time or aren't skilled in assessing literacy. So if you look at the literature, language barriers have been identified as a significant barrier to access for some African immigrants. So language is clearly an issue that oftentimes is overlooked. There are federal regulations mandating language services for limited English proficiency patients. but there's an evidence of underuse of translator services, whether they be by phone, video, or in person, particularly amongst physicians in training. So residents and fellows tend to underuse these because they're under time pressure. So that's an unfortunate thing that needs to be overcome. And then, as I mentioned, there are deficits in physician ability to assess patient literacy, and I would bet that there are deficits in many people's ability to assess patient literacy. Okay, so let's move on to the next case. So Mrs. Moniba is a 40-year-old woman living with HIV from Liberia. Her husband is also HIV positive. He lives and works in the U.S. She travels to see him twice yearly and recently saw an HIV doctor here in the U.S. because she wanted to receive Western-style care. She's been taking a regimen that included efavirenz since she was diagnosed 2 years ago, and she complains of poor sleep, fatigue, and strange dreams. The doctor would like to switch her regimen. So you consult with the doctor and say, wait a minute, let's slow down. What do you think, or what would you tell the doctor to do? Find out more about her symptoms, find out about her travel plans, go ahead and switch her regimens if she's having these symptoms, check about alternate medications. Now, I need to explain what I was saying there. So check about alternate medications in her home country. So the system doesn't allow us to say all that, but that's what I meant there. Are you unsure about what you would tell the doctor? Do you think maybe, find out more about her symptoms and her travel plans and then check out alternative medicines in her home country? Or you do all four of the top things, so 1, 2, 3, and 4. Sorry, that was complicated, but I think you guys get the gist. Okay, so let's skip to results. So I think most people picked 1, 2, and 4, and I'm going to need to just move on and go to what 1, 2, and 4 are. So So 1, 2, and 4 would be find out more about her symptoms, find out more about her travel plans, and then check for availability of alternate HIV medications in her home country. So that's exactly what I would say to do here. Now, the point that I want to make here, first there's some simple points. Obviously, if you're just seeing this patient, efavirenz, some HIV medications cause XYZ symptoms, but you don't know her well enough to know that that's the only cause of her symptoms. Find out more about her travel plans. Is she going to be your patient, or what is she doing? I literally do have patients who travel back and forth. I have a couple of patients who see me a couple times a year, and they may be seeing other people. And I do sometimes occasionally talk to their doctors in other places, but they prefer, for a variety of different reasons, to get care here. So you want to find out exactly what it is she's doing and what her plans are. And then lastly, check for the availability of alternative HIV medications in our home country. Okay, so this is really important, and I've seen this happen with other African and other immigrants, actually. So not every immigrant is bound to the U.S. I mean, there are folks who are on visas, they're, permanent residents that can travel, they travel back and forth. I think this is important for us to recognize and realize that people are migratory. There are many medications that we have here that are not available in other countries. I mean, your medications, I'm sure you guys have heard of, like Stribals, that's not available other places. I mean, certain categories of medications are not available. So if you're ever trying to think about, okay, well, or a client comes to you and says, well, my doctor, they switched me to this medication, but now I'd like to go home for 6 months, but Mass Health won't give me 6 months worth of medication. I'm going to need to find the medication at home. You got to kind of go back and kind of strategize as to what it is you're going to offer the patient, so they don't run out and say, oh, well, I can't switch to a different medication. What am I going to do? And they, it becomes a problem. So there is information online at the website that I give here. That data is going to be updated very soon, and they'll have new information with the updated guidelines. Each country has their guidelines where it says. I actually look at that. I have a patient who travels back and forth to Ecuador. I looked at that, and I have him on a regimen that I may not have him on if he was here. I have another patient who is Liberian who I, have him on certain medication because, it's best that he be on that so that he can get refills if he can't get back here. And he recently, because of the whole Ebola thing, he couldn't get back. So, there are all sorts of things that you need to pay attention to. The other thing that you need to realize with migratory populations is that they may be infected with a different subtype of HIV. Now, I realize that many of you all are not clinical providers, and this isn't so important for clinical care, except to say that, there are different types of HIV. There are different subtypes. Okay, here in the U.S. and in Western Europe, I think Japan and Australia, subtype B is most common, but other subtypes are common elsewhere. Subtype C, subtype D, subtype A and H are less common, but they're around in sub-Saharan Africa. And according to a number of studies that have come out, some of these subtypes may progress faster than the subtype that we see most commonly here in the States. Now, definitive evidence about this isn't quite clear, and we certainly treat all subtypes the same, but if there are strange things that you're seeing in your patient, it may just be because they don't have the same subtype of HIV that we're used to seeing. You also have to pay attention to the fact that there's an ongoing risk of co-infection with patients who are traveling around and not all, sort of staying here in the U.S. I'm sure you guys have heard, if you do any sort of international travel, that a lot of people who are from sub-Saharan Africa or from places where malaria is endemic, they don't take the prophylaxis that everybody else takes when they travel. That's actually not appropriate. Malaria immunity actually wanes, and you do need to take prophylaxis. Certainly TB is endemic in many parts of the world, and your patients who are living with HIV who are traveling somewhere who haven't been exposed to HIV and haven't been given latent TB therapy, they could be exposed, so that's certainly an issue. And then Dr. Kwakwa already spoke about hepatitis B and the ongoing issues as far as that's concerned. So there are lots of things that can happen with patients who are traveling around who you don't really know what exactly their exposures are going to be. So all these patients need to have culturally competent travel advice. Somebody needs to be talking to them and making them realize that's important, because I found with a lot of my African patients in particular, they just don't see these issues as important. They feel that, okay, well, I've been here for 2 years, so what if I go home and, I'm drinking the water, I'm doing all the things that I would normally do, and those exposures can be dangerous for people living with HIV, particularly if their immune system is compromised, but even in some cases when their immune system is normalized. Okay, so just in conclusion, just a few comments. I started out by talking about how more data is needed regarding prevalence and clinical outcomes amongst African immigrants and immigrants in general living with HIV. It's hard for us to say much about this population when we have such scattered data. Addressing stigma and barriers to disclosure is critical to improving the quality of life of Africans living with HIV. I mentioned mental health issues. PTSD, as well as generalized anxiety and depression, should be recognized and addressed in a culturally competent manner. You really have to understand where somebody's coming from, what types of treatments they would like to be using, and whether or not they even recognize that they may have these mental health issues. And then this issue of linguistic competency and increasing health literacy, that's really key to providing high-quality care to all patients. So I think that's it. Thanks.
Thank you, Dr. Ojikutu. That was an excellent presentation. In closing, we would like to inform you about the National African Immigrant and Refugee HIV/AIDS and Hepatitis Awareness Day, also referred to as NIRA. The purpose of NIRA is to bring national and local attention to the HIV and viral hepatitis needs of African immigrants living in the U.S. in a culturally and linguistically appropriate manner. The creation of a National Awareness Day will also support the eradication of other endemics fueling or related to HIV disparities among African immigrants, including tuberculosis, substance use, and mental health. For more information about NIRA, please go to www.macboston.org. Also, each organization and individual can join the initiative and host an event on September 9th. And one of the things that I just wanted to add here is that we talk a lot and we heard a lot in this presentation in terms of the advocacy that's needed for the African immigrant and refugee community. And we talked about data and research being part of that. And when we think about what it actually takes to end health disparities, it's really a comprehensive plan that will get us there. And so advocacy for this day is incredibly important because it will raise awareness, which we hope will end stigma in that community.
And thank you for participating in this webinar on the epidemiology of HIV/AIDS and hepatitis B among African immigrants, current status, barriers, and challenges. As part of the series, there's one remaining webinar on Monday, June 15th from 3 to 4:30 Eastern Time, Improving Hepatitis B Prevention, Screening, and Clinical Care for African Immigrants. Please register at www.neatec.org. If you have any questions, please contact Chioma Nnaji. Contact information is provided. Immediately after we close the webinar, you will receive the evaluation. Please keep your web browser open and the evaluation will appear immediately. Please complete. The evaluation will provide vital information to help improve the webinar and also document who participated. Attendees who are requesting nursing and social worker continuing education units are required to complete an evaluation form. A certificate will be emailed and/or mailed to participants within 4 weeks. Thank you again.